I know it's too late. Most of us are going to sleep now. Second issue, it's very hard to speak after Dr. Muhammad Omar Al Farouk. Every time he comes with enjoyable, enjoyable presentation. Dear colleague, our talk today will be about the heterogenic venous injuries. Let us say over the past 50 years, additional advances in managing vascular trauma has been made in both civilian and military practices. The trauma-related venous thrombosis, it's difficult to be treated because of the hemorrhage versus anticoagulation. It's very hard to give anticoagulation in the presence of hemorrhage. As regard the heterogenic venous trauma, we have both peripheral and truncal. I prefer to get a peripheral one because the morbidity, mortality, death have been decreased. We are speaking about just thrombosis. Other side, the truncal one, it's a life-threatening condition. The rising of therapeutic and diagnostic techniques involving cannulation of veins, it has been raising the incidence of heterogenic venous trauma. By the way, it counts like about 10%, 9% from world death. Here we have a paper from Reagan and his colleague. They were talking about the effect of vein repair on the risk of venous thromboembolic events. It was reviewed more than 100 traumatic patients. They concluded that the ligation is the most common modality for treatment of such cases. So they recommend just ligate the peripheral veins. Let us say in one sentence, the primary repair is important in proximal arms or leg veins, the veins which drain the majority of the axial outflow. Let's go to another area. It's the neck zones. In the simple words, zone 1 usually require median sternotomy for proximal control. Zone 2 in the neck, direct surgical exposure through anterolateral cervical approach. Zone 3, it needs a neuro radiologist and better to be treated endovascularly. The internal jugular vein, it's more common in our practice. If we have a unilateral injury in the internal jugular vein or bilateral, unilateral ligated if you are expecting more than 50% stenosis. Bilateral, it's a must to do a repair for one of them. Because if you ligate both of them, you will go a cerebral venous congestion with high mortality rate. Abdominal vascular injuries, we have principles or basics. Principles, debridement, gentle balloon catheter, thromboembolectomy of both inflow and outflow prior to vascular repair. Abdominal zones, we have 3 zones. The middle one, or zone 1, the central area, it contains the major branches, aorta and its main branches, the IVC and superior mesenteric vein. Zone 2 located laterally, then zone 3. In zone 1, which is important for us here, is the IVC injury. Professor Nasser will talk in details about the IVC injury. Just direct sponge, proximal and distal, then you are going to control the IVC. Let us classify the IVC injury into infrarenal, juxtarenal, suprarenal. The infrarenal one, ligate it if you are expecting more than 50% stenosis. Juxtarenal, repair it by division the left renal vein. The suprarenal one, you have to repair with Dacron grafts from 18 to 20 millimeter supportive PTFE or Dacron graft. Here, let's transfer to the zone 2. Zone 3, the iliac vein, heterogenic iliac vein. Sometimes we do it endovascularly, and sometimes we need to division the right common iliac artery just to be able to repair the internal iliac vein. Zone 3, try not to go there. unless expanding hematoma, intraperitoneal leak, absent or diminished femoral pulse. We will let the IVC for Professor Nasser. Simply أقولها بالمرة. We had a study right now. We are going on it. It's a part retrospective, and the other one is a prospective study about the endovascular management of a iatrogenic vascular injury, and it's an invitation for all of us to transform it from single center study to a multicentric study. We have found many veins and many arteries. Let us say here we have a common femoral aneurysm. We treated it with covered stent. This is a pointer. You can see, right? We don't need for pointer. And this is a vertebrojugular fistula. It was a fistula between the vertebral artery and jugular vein. We treated by coiling, and this is the follow-up 1 year after that. Don't miss the EG-VASC, inshallah, on the 30th of November in Luxor. We are inviting all of you. It honored us, and thank you. And I don't want. I hope to be enjoy with the only 7 minutes presentation. Thank you.